Welcome to the latest episode of Lateral Think, brought to you by Melbourne Athletic Development. Melbourne Athletic Development is a sports and injury management clinic based in Melbourne, Australia. To maximise your performance, optimise your injury management, contact the team at Melbourne Athletic Development. As many of you know, Jack and I have a very diverse understanding across multiple areas of practice, whether they relate to sports performance, say for instance with my background in track coaching, or with Jack and his background in yoga practice. We've combined a lot of this knowledge over time with our clinical and sports performance experiences to really develop what we do. And as you know, we love education. So what we've tried to do is take that knowledge and put it into an online learning community. We think this is important because it's an opportunity for people to interact, learn, and upskill as they try to improve the practice of what they do. So if this is something that you would be interested in doing, head to melbourneathleticdevelopment.com.au/education and get an understanding of how you can upskill your current practice. Hello and welcome to the latest episode of the Melbourne Athletic Development Podcast. Today, Jack and I are going to explore some ideas around intellectual ego, which we think is kind of an interesting topic. We've had a couple of interesting things happen that we think will actually give us the opportunity to explore some ideas that maybe you haven't thought about, and maybe they might be helping you or they might be hindering you in terms of your professional development. For those who have listened to us ranting about different things, you'll know that education is a really big part of what we do. And I think both of us, in a very, I would say humble way, we try to explore new ideas and we're very curious, which I think brings up one of the issues that we had. But anyway, today, Jack is actually still overseas. So thank you for joining me, Jack. I'm back in Melbourne and we reversed positions. Jack's now actually in Italy. So how are you going there, Jack?
Yeah, no, I'm doing well, John. Back over in Italy doing another stint of my fashion manipulation coursework, which is always good. It's really interesting to come over here. And like as I mentioned before, I think one of the things I always find interesting and insightful, and it's certainly relevant to what we're going to talk about today, is typically, well, I'm the only Australian here. I'm surrounded by people from all corners of the world who have who are mainly a physiotherapist, but actually have different perspectives, different philosophies, different exposure to different areas of research and information that we typically don't get exposed to in Australia. And I think this sort of fits in, or it's a good segue to talk about what we want to start with. And then that is thinking about the psychological or emotional
Mm.
response or reaction that we actually have to things that we're unfamiliar with. Because
Yeah.
although we probably would like to think that we do things really well in Australia, and don't be wrong, there's some great things and some great strengths about physiotherapy as a profession in Australia, we also have to acknowledge and realize that there are limitations that we have and certain biases that we have as well. We get exposed to certain ideas or certain areas of research, but there are also things that we don't get exposed to. And there's a important discussion to have about how we respond to things that we're unfamiliar with, because that in itself can be a challenge to the mind, to the ego.
Oh, definitely. I had a good conversation with a friend of ours who's been on the podcast, David McCloskey, about this, and the cognitive dissonance that occurs at the moment you realize you have no idea what the other person is talking about. And you've got to
Mm.
make a decision about whether you say, "Oh, I don't know much about that. Can you explain more?" Or you pretend like you actually know what they're talking about. Yeah, oh, yeah, I've heard of that. Um,
Yeah. And I know we've talked about this before too, where you often see differences about people's response to what they don't know and whether they're open to actually say, I don't know about this. Because
yeah.
I think, particularly for younger clinicians or for younger people in general, there's often that overconfidence or belief that you think you have an understanding of everything, as opposed to typically the older you get, it seems that older people are much more open to going like, oh, actually, that's interesting. I don't know what you're talking about there. Can you
I,
elaborate?
I think that that's actually been a really common theme with the more experienced and the more interesting people. Like, there have been people who have probably kind of brushed it over, but I actually think that the more interesting and more curious practitioners that we have, and this is across different things, not only just medical, but that we've interviewed or had on our podcast for discussion, the ones that seem to be still very heavily invested in their own learning and are very curious are the ones who are the first to admit, like, oh, I don't really know much about that. Can you tell me a little bit more about it?
Mm.
And that's, I think, is an interesting observation, because they're the ones who I always think seem to come up with the best ideas. They come up with the most interesting things. They're always tinkering, they're always playing with things. Whereas the ones who, they might be very successful clinicians, but they're not necessarily innovating, are the ones who kind of just like, oh, yeah, okay, fair enough. Like, I'm not going to ask you too much about that topic because I don't know about it.
It's interesting you say that, because I just actually think about my own experiences here with fashion manipulation, where you actually get a lot of people from around the world who are in their 60s or even 70s who are doing the course, and
That's interesting. Yeah, yeah,
it's completely new to them. And it's quite interesting where a lot of them will say the same thing of, I wish I'd learned about this when I was younger. And often the older people are people that come from countries where FM is not that big. But there are some younger people that do the courses as well. But typically they come from the countries where fashion manipulation has been more adopted already. So they get exposed to it when they're studying or even when they start working clinically of, oh, you should go and do this coursework.
yeah,
And because it's more accepted and adopted already, you're more likely to see younger people doing it, as opposed to some areas of the world where they're almost towards the end of their career, but then come across and go, I need to learn about this, which is an
yeah.
interesting insight in itself, because I often think of, why do you have the desire to do this now when, you might be retiring in 5 years? And part of that,
Well,
though, I think
it's
is
credit
those
to them,
people.
isn't it?
Absolutely. Yeah. Yeah. Um, it's it's that in itself, I think, is actually quite an insightful thing. And it's interesting to talk about something like fashion manipulation. It doesn't have to be FM. It could be other different methods or other areas of research, or whether you see that similar pattern where, because of the profession that you're in, or what is particularly emphasized within your country, within your profession, of what happens when you get exposed to a new idea, and does that actually align with your philosophy? And if so, are you more likely to adopt it,
Well, I
or is it
think,
the opposite?
I've got an example of that, because I think that's something that, we talk about this stuff a lot, because obviously you're learning more about it, and I'm trying to pick up information from you, and we're passing some of this on because we want people to know about what we're learning about and all that kind of stuff as well. But one of the things that I think that this happened with was obviously with the research that was done out of the hamstring injury group.
Hmm.
Um, as you know, like I've slowly been putting together, and it should be finished very soon, is the hamstring course that we're putting on our education platform. There's a sneaky plug for you, Jack. Um, but is the research that was done mostly out of Australia, looking at the use of, say, something like Nordic loading as an eccentric, loading task.
Mm,
And there are a number of proponents, particularly of even older clinicians or sports performance professionals, who just push it back against it so strongly. Not because they
mm,
necessarily see anything wrong with that, but they are actually trying to say to people, like, put this in context. You can't be, and one of the big proponents of this is actually a strength and conditioning coach, which I won't go into it, but he's an older guy, and he's seen every evolution of, different loading go on.
mm,
The thing he was pushing back against was not the use of a Nordic exercise, even though he says, like, I don't really use it, but I understand why you would use eccentric loading and all that kind of stuff. His pushback is the wholesale adoption that that's the only methodology you should use now for hamstring injury management or hamstring injury prevention. And he's saying to people, like, don't become indoctrinated. Like, you still need to use your brain, and you still need to think about the problem much more broad than just because a new piece of research came out. And I think, in reverse to what we're going to talk about, a topic that seems to be evolving, which we find quite interesting, seeing it play out. But is like, no matter what happens, whether it's a new piece of information or whether it's an old piece of information that's changing, it's really important that you keep an open mind. And I know in preparation for this, you said, the word that's really important is like having a mindset of wanting to explore new information and being
mm,
open to that. I
mm,
think that that's something that if you have ever, if and it's hard because you can become closed when you see something is effective. You're like, well, the story's done on that. Like, we don't need to keep exploring this. But that's dangerous.
Yeah. Yeah, absolutely. And just speaking about, for instance, the topic of hamstrings and Nordic hamstring exercises. And again, I think this is important to not dismiss that it doesn't have value or benefit,
Oh, it
but
definitely
it's
does.
it's it's the oversimplification of this is the panacea to all hamstring
And we've
training.
worked it out. It's done.
Well, and the other one I think too, and this is goes to our conversation we had with Tony Blazovic,
Yeah.
is what is the mechanism behind it? Because the narrative at the moment is, well, it improves fascicle length, and that we know to be really important for muscle tendon biomechanics and mitigates injury development. Where someone like Tony Blazovic, who has much more knowledge in the area than we do, would actually go against that to say, well, it's actually just not that simple.
Yeah, we don't
Um,
understand it well enough to say that that's the simplistic and reductionist kind of approach to being like, it's definitive, it's this. It's not that simple.
No, no, and look, I can even say just from um, working at a university in a postgraduate program where we're doing a lot of stuff on exercise science in musculoskeletal and sports injuries, you very often hear the same narrative of it improves fascicle length, it improves fascicle length, it improves fascicle length, and that in itself, you have to ask yourself, is that actually reflective of the research? And if it isn't, is that reflective of the very strong narrative that we have at the moment? Because you need to be able to dissociate those two things. Because what may be seen as, oh, well, like, there's no point even having this discussion. It's obvious that this is what it does.
Yeah.
You have to be able to differentiate, is that actually reflective of what we know from research, or is that just the built in narrative that is within our profession that leads us to that conclusion? And I mean, we see these narratives very strongly within, again, our profession, particularly within Australia. I think the other big one that we've talked about before is manual therapy, where particularly for younger clinicians, or particularly for a lot of lecturers at universities, there is that very strong narrative of there is no value to manual therapy, it doesn't do anything. But we have to take a step back and think of, well, where does that conclusion come from? Is that
Mm.
actually reflective of what we understand from a research perspective? And I think the other big one is that reflective of what we know from a clinical experience. Because often the belief system that you have may not align with what you would call evidence-based practice.
All right. I think we jump into the topic of the sort of paradigm shift we're starting to see or being explored, which you put forward this idea because I think it is starting to become a bigger discussion, which is non-specific, particularly back pain, right?
Mhm.
And for those people who have been following what's been going on with people like Paul Hodges, he's starting to do much more research on trying to understand some of the mechanistic parts of that. And I know that you've also got another paper that you recently presented to our clinical group about that, or about non-specific pain and the interaction, particularly with, say, the connective tissue system. Um, do you want to start explaining to people a little bit about how this narrative is starting to change? Because previously it was always, okay, there's mechanistic, you know, pathology of a specific structure. You know, it's a pathoanatomical model, it's a disc injury, it's a facet joint injury, it's some sort of structural damage, or it's long-standing, non-specific chronic low back pain, and we just don't know what's going on, and you've got to go get
Mm.
psychology input because you're clearly, mismanaging the perception of pain.
Yeah, and I think a really good starting point to ask ourselves as clinicians is, do you think we can do better than identifying or classifying someone with non-specific back pain?
Yeah.
Because personally, I really hope that the answer to that is yes.
Well,
Because this
I don't know about
idea,
you. Did you? I always used to feel like that was such a cop out, and I still feel that, even though I don't have an answer to what potentially is driving that non-specific presentation. To me, it still comes across as a cop out. Like, well, we don't understand this. We're just going to label it, and then we'll just move on.
and this is where I think it's very important to differentiate the academic um, classification or conclusion versus the clinician's classification or conclusion or application. Because again, there's reasons why we've come to this conclusion of non-specific pain. And again, part of this requires us to think about in Australia, we particularly when it comes to back neck pain, we are very joint centric or articular centric. And part of that also comes into understanding that when we think about diagnosing a problem, we do really place a lot of emphasis on radiological findings. So, is there a particular pathology within the disc or the facet joint? And part of that also requires us to think about the correlation between certain pathology and someone's presentation. And then the other, consideration is maybe bony type of pathology when you think about things like stress fractures or fractures.
Yeah, but even in not in non back pain related areas, like I think we're very quick to jump to only structural items, as you said, we image well. Like obviously, we speak about in the hamstring injury presentations about classification and the different
Mm,
imaging that's been used in some of those classification systems, the British one, the Barcelona one, like there's all these different classification systems, and some of them use both clinical as well as imaging findings, but they're
mm,
so heavily driven towards, okay, is it the tendon? Is it the muscle? Is it the muscular tendinous junction? They do speak about things like connective tissue, so we're not saying that they don't. But I find it's really interesting that the driver of it is being able to label a very specific item. And I don't, for those listeners who have listened to the podcast that we did with Tony Blazevich, I think it was really interesting with him. He seems to skew very heavily towards like the tendons involvement, say, in biomechanics. Um,
mm,
and I think we tried to push him a little bit with that and say like, okay, well, what about the other connective tissue structures? And he was like, yeah, so the
mm,
tendon. And we're like,
mm.
okay, what else? Um,
Yeah, yeah.
and not to say that he's not right. He's done a lot more research than we have, and maybe he does understand it to a point where he can say to us, "No, you're missing the point," or whatever. And we're open to that. But I think it's interesting that we all, even at the level that say someone like he is, we have that bias to want to bring it back to the things that we know or the things that we
Mm,
understand, or as you said, the things
mm.
that are in our wheelhouse of clinical experience or even what we've read. Like, oh, I've read about this, so therefore it fits nicely within my little intellectual kind of hub of information, and I'm comfortable with this. Um, and that in
Yeah.
itself creates an issue.
Yeah, and I mean, for both examples, whether you're trying to uh, classify or identify back pain based on radiological findings or a soft tissue injury, there may be a correlation between those radiological findings and someone's presentations, but that correlation isn't always very strong, which in itself gives you some information straight away of going, well, clearly I need to consider other factors here because as we know, with say disc pathology, there can be poor correlation to someone's presentation. But even with hamstring strain injuries, where don't get me wrong, there is some correlation between the severity of tissue damage and what tissue is involved. But again, if you look at some of the research behind this, the variability in someone's outcome to say return to play or sport
Yes.
is highly variable still. And so, this comes back to us as clinicians asking, well, what is the gap in our understanding? And now, when I think about back pain, we need to be very cognizant that we are very articular centric. Yet we have many other tissue structures around the back, as we do in any other part of the body, that we know can generate pain. And of course, as we've spoken about many times, I'm talking specifically about the myofascial system here where, and this comes back to the article that I recently did a presentation to for the clinic, which is looking at some of the chronic long-term maladaptations within the connective tissue system associated with back pain. Because this isn't something that is necessarily speculative. There's actually a lot of research showing particular changes that occur. And this can be with things like the development of things like myofibroblasts, so more active contractile components within the connective tissue that lead to things like increases in passive stiffness. And then also other factors when you think of the changes in the connective tissue, or sorry, the chemical environment in terms of an increase in the abundance of pro-inflammatory mediators, which is also shown to increase the density of nociceptors.
So
Now,
in terms of that, before you go on,
yeah, sure.
what does this present like when you actually have the patient? Is there physical things or clinical symptoms or signs that may actually point you in the direction that actually we are seeing some of these changes that you've just mentioned?
Mm. Um, there can be, but there is obviously variability in their response. And some of the obvious ones are some of these changes with an increase in, say, passive stiffness may be associated with a reduction in range of movement.
Mhm.
But it also helps to explain that when you step outside of thinking about the typical patterns associated with discogenic or facet joint pain, of understanding that the production of their symptoms may not necessarily fit with a clear mechanical pattern, in that it can be multiple movements that generate their pain. It could be also with mechanical movement, or it could be associated with being in a stationary environment, because when you are more stationary, you're going to get an elevation in stiffness, which again is more likely to sensitize those nociceptors. But it also helps to explain the variability in where the pain is, because if you have an increasing amount of maladaptive connective tissue, you can start to get pain generating in different areas of the back. And it may not necessarily always be specific, because it may be, for instance, some parts of the thoracolumbar fascia get more aggravated after certain activity with the upper body, because it starts to create more tension in certain parts of the thoracolumbar fascia, versus, say, using the lower legs, which might create more tension and irritation of other parts. So
And
it does actually.
do you think that that's specifically because of how complicated the connective tissue environment is of the spine, that you typically may have pain that is coming, and the origin of that pain may be from somewhere else? It means that the imaging in itself may not be as effective at identifying where that source of pain is being generated from.
Oh, absolutely. And to be reasonable, I think we also have to understand that this idea of myofascial pain at the moment is typically a diagnosis of exclusion as
Yes,
opposed to exclusion, which it needs to be criticized in itself, that there needs to be more work done to be able to go, well, how can we more effectively or easily
classify, label,
diagnose,
and put this in. Yeah,
cor- correct, and see these changes? Because if you look at, say, a tissue biopsy, we definitely can do it, but I do think it's important from a larger adoption at uh, within the medical system to be able to see some of these changes much more easily and effectively. But I think it also highlights for us as clinicians that we need to be thinking about what kind of factors influence the environment and the mechanics of the connective tissue,
yeah. I was going to ask you
and
about
what.
this because I think that this is one of the more interesting areas. You're going to go into talk about systemic kind of involvement.
I mean, I think there's two elements to it, and
Okay.
we've talked about these two components in other presentations, but there is certainly the mechanical stresses that the tissue is being exposed to, and then also some of the systemic or non-musculoskeletal factors that influence the remodeling of the tissue. And this actually helps to make sense of a lot of presentations that we see, particularly, well, not just in the general population, it can be actually any population group. But going back to the point you made before about when you look at the connective tissue, particularly in the lower back, if you think about the thoracolumbar fascia, it's a pretty complex and complicated structure. And it's actually, from an anatomical standpoint, it's been very well documented in understanding that there are different layers involved, that there are a lot of different connections of muscles to the thoracolumbar fascia, ranging from the abdomen, the gluteals, the latissimus dorsi, but even other muscles within the back. Um, and so, and that has different layers, which, if we're exposing our body to different mechanical stresses from the upper body, from the lower body within different
Yeah.
directions, maintains a normal amount of gliding and sliding between these layers, which is very clear as an important element for its normal physiological behavior and to mitigate the development of pain from those nociceptors. So it makes a lot of sense when you think about particularly people in the general population who, for the majority of them, are not doing any physical activity. Are you maintaining adequate mechanical stresses that maintain the normal biomechanical behavior of the thoracolumbar fascia? But even for those people who are active, or particularly if you're involved in sport, are you providing adequate stresses in different directions within different parts of the body that connect to the thoracolumbar fascia that maintain its healthy state throughout the whole structure. And that in itself gives you a lot of information, insight into understanding why people develop certain problems. And I think, particularly when you think about athletic populations, where you might be thinking, okay, they are physically active, they are applying mechanical stresses to it, but the complexity of those mechanical stresses may be reduced because the demands of their sport only require sagittal movement or frontal movement, or they're very lower limb dominant, or and the list goes on. And this is a useful thing to help us understand and appreciate the development of pain in the back. And you could apply the same principles in the neck of, okay, does this fit into what we would consider to be a classic diagnosis when you think about um, joint pathology? And we're talking specifically about the disc, the facet joint, or the bone. Or does it fit into that more non-specific category, which if it does require us to then think about it from a mechanical, but then also a systemic factor, which we can talk about in a moment, to think, are there limitations or deficits that we need to identify that will help to restore its normal behavior?
Do you think that like the better practitioners are already doing some of this stuff, or do you think that the literature is ahead of where, or is starting to explore areas that potentially aren't or haven't been explored before?
Oh, look, I think it's a bit of both. I mean, I think there's always plenty of clinicians out there who, particularly through their own experiences, start to identify particular patterns with certain presentations in certain population groups, and identify there are particular deficits with the types of load that they're applying through that region of the body, or there is benefit in using certain types of manual therapy. And I think it is important to highlight too that, this isn't just me like speculating here. There's actually very good and well documented research to highlight some of these maladaptations. And again, I think a really important thing to remember as clinicians is make sure that we can identify and apply first principles that come from research, because it doesn't really matter what area of research you look at within our profession. There are always limitations in terms of the quality of research or
Mm.
the amount of RCTs that are done. The purpose of us as clinicians is not to just say, well, what does the systematic review say? We probably actually need to dive a little bit deeper and say, well, what research is there to in this particular area? If there is conflicting research, why is that the case? Are there differences in participant characteristics in the classification systems that they use? Is there variation in the interventions that they use? Because that gives us information about understanding what may be effective or may not be effective, or why something did work versus why something that didn't work. And I think more importantly for us as clinicians, it gives us more information to be able to make decisions, or perhaps gives us more insight into other variables or other things that you need to consider that are going to be effective at applying a plan that's effective for that individual, as opposed to this perhaps oversimplistic idea of, well, it doesn't fit into the classification systems that are very well recognized. And because it's non-specific, I'm just going to give them generalized exercise or explain pain because they need to understand that belief systems are a big driver to their presentation, which again may be the case. But I think we need to make sure that we don't forget about some of the key modulators associated with things that influence pain or the behavior of tissue that may be associated with someone's presentation.
Mm. Before we move on to some of the issues that you've brought up there, do you want to quickly mention some of those systemic factors that are probably also driving some of not only the perception, but maybe some even the sensitization process that can occur around some sort of level of change within the tissue that is there?
Yeah, look, absolutely. I mean, we've spoken about this before, but I do think it is very important to highlight because we are biological systems. And I think, actually, it's perhaps a conversation for another time, but we need to make sure that we remember that we're not just it's not just mechanical stresses that influence the behavior of tissue, but also the chemical, neurological, and hormonal environment as well. And again, this comes back to some of the research that's emerging from Paul Hodges' group in particular, of understanding that yes, mechanical stresses are a very key factor that influence the remodeling of tissue, but that is also happens in conjunction with the chemical environment. And this really is highlighted through the fact that our immune system provides the signals for how our tissue changes and adapts. And it doesn't matter whether you're an elite athlete or you're within the general population, other lifestyle factors, and the big ones are the ones that we always talk about: diet, sleep, the types of mechanical stress, um,
Nutrition. Yeah.
exposure
Yeah.
to sunlight is even a big thing.
Yep.
The list goes on.
Yeah.
Those things regulate our immune system and will determine the amount and type of cytokines environment within the local tissue that you apply mechanical stress to. If we don't have that adequate environment whereby it provides the right signals to upregulate certain anabolic and catabolic pathways in a particular sequence, that's when we start to see maladaptation. That's when we start to see the increase of, say, fibrotic tissue formation, which creates non functional tissue. So, this again helps to make sense that, again, as clinicians, we do need to think about the mechanical stresses and what type of mechanical stresses are being applied. But if we're not identifying what other factors influence the remodeling of the tissue, that's when you'll start to see limitations or a slowing down of uh, the change that we expect to see to restore normal mechanics and reduce someone's pain. And this is something that's very evident when you look at something like back pain. And again, it could be what you consider more non-specific or myofascial pain, or it could even be related to disc pathology. That if someone has a systemic environment that is typically more pro-inflammatory in nature, that's when we start to see more fibrotic tissue form around the erector spinae muscle, which will affect its behavior and ability to contract and recruit, which again is going to affect the behavior of the overall thoracolumbar fascia, that over time, again, further generates more fibrotic tissue, an increase in density of nociceptors, and therefore the development of long-term chronic pain.
Hmm. Sorry, I was playing with my phone because I'm trying to get a quote up because I don't want to stuff it up because I think it's important for this next section where
Mm,
obviously some of these things that we're speaking about, some people would be saying, yes, yes, like that makes sense. And I think that, hopefully the research starts to elucidate more understanding of the mechanisms that behind, the development of this pain that previously was lumped into non-specific. And we might have
mm.
some better ways to manage people who present with, non non-mechanical or non sort of pathoanatomical presentations of back pain that don't seem to be explained in a very simplistic manner. And then other people are probably hearing this saying, like, what are these two idiots talking about? And,
I often ask myself that question as well.
and you and I had an experience recently that I think really highlights this. And I want to put this forward because we found it actually curiously interesting.
Mm,
And it's one in which we went and did a presentation to a clinical group. And it was about some of the ideas that we obviously discuss on the podcast, the framework that we've really tried to develop with our clinical group, some of the concepts that we're exploring, and some of the pieces of information that we think are being drawn into our clinical experience. And obviously, everything that we do, we always look for evidence to support what we're doing, and we're always constantly exploring new areas to see how that fits into um, our clinical experience and our ability to get good outcomes for the patients that we see. Like we very selfishly, I think we've said this before, but we very selfishly started this podcast to talk to people who we could learn from, because we wanted to
mm.
be able to reach out to people that previously maybe we wouldn't get the opportunity to talk to in a more long form sense, right?
Can I just actually add there for a moment? Because I think it's actually important to highlight this. And I think this is what you meant anyway. If the way that we go about developing our framework and the things that we talk about is not so much of we find evidence to support what we believe.
Confirmational
It's the other
bias.
way around.
Yeah.
It's like we come across research going, hang on a second, like I've never heard about this. Like we need to look a little bit more into this, and that gives us information or ideas about, is this another modulator or factor that we need to consider? Because like the reality is, there's lots of things that we don't know. So this is the value of research and looking at the larger body of research. And I think that's a big thing that we try to highlight is get exposure to breadth so that we can get ideas or insight into things that we don't know, to then think about being able to create a better clinical picture of, well, what factors do I need to actually address for this person's problem? Like,
Yeah, no, I appreciate that because I think that's very, very true, in our case at
mm,
least. But what happened with this presentation is we asked for feedback because we're still trying to get this information across to people, and we want to know what people think and whether they can engage with it and they feel like it's actually assisting their understanding of things. So we sent out a feedback form, and most of it was positive. So we're like, oh, we're doing good here. And then we got one which curiously said, well, most of it was all rubbish and it seemed like mostly pseudoscience to me. And
mm,
Jack and I actually had a really interesting discussion about this. And we said, we haven't done it as yet, so we will aim to do so. But we really want to understand why that person thought that was the case.
mm.
And on reflection, I think both of us sort of thought, okay, well, is there anything that we put in that presentation in particular, or anything that we said that wasn't supported by a level of evidence that we think is reasonable? It's not,
Mm.
we haven't taken it from news.com or something like that, right?
Reddit.
Yeah. So we went through that process and we thought, okay, most of it's supported. Now, we understand that some of these concepts are new, and maybe we delivered it in a way that potentially was, quite relaxed. We try and engage with the audience by telling stories and trying to give clinical, scenarios and things like that. So maybe they didn't engage with that, and that's okay. But one of the ideas that we came to was, okay, is there a possibility, and we're going to ask this person, that maybe because this person hadn't been exposed to some of these ideas and it actually really challenged what they currently understood, that it potentially was quite confronting for them, like we mentioned at the start of this discussion. And I think that may be a part that plays in. It might not be the whole part, and we'll obviously find out, and hopefully we can update you in the future if we were way off base and maybe we were talking rubbish, and we'll apologize and try and correct our errors. But I think the thing that was really interesting about it is the concept is framed, and you were very right on this, Jack. We spoke about this before we did this podcast yesterday, of what is the framework or the philosophy of physiotherapy, of health,
Mm.
and particularly in the context of Australia, of where we are. What is the philosophy and mindset that underpins that, right? Because currently, and we've spoken about this a lot, we spoke about it in our evidence-based practice discussion that we had a few episodes ago, that we have this mindset that if unless it's been done in an RCT, or at least some factions of physiotherapy, then it's complete and utter garbage and you shouldn't use it and it shouldn't be considered best practice, right?
Yeah.
And I think any experienced clinician will tell you if you do that, then you'll have almost nothing to do. And most of the outcomes that you get might not be that effective for the population that you're dealing with because it just hasn't actually been conducted as a randomized controlled trial for the population that you're dealing with.
And look, I think we even need to extend this idea of ego and bias to researchers
Oh,
as well,
massively.
because I mean, and these are conversations that we've had with researchers, that just because you're conducting research doesn't mean that it's purely objective and that you don't have your own
Agenda.
agenda or belief systems and ways to support your own hypotheses. But it's actually a really important conversation to have, and something that I don't think is discussed a lot is we all need to remember that we have our own biases, and that's okay. There's no such thing as pure
No.
objectivity. And we need to understand that in Australia, within our profession, we have our own biases. And look, I think a lot of the time too, you can see a lot of physiotherapists get on their high horse of thinking, we're better than chiros, we're better than osteos, and the
Yeah,
conversation
that's
goes
that's a
on.
huge bias that I think that we lose
It,
opportunities to learn from people because we have this idea that there's a hierarchy and, for instance, that we're intellectually superior to these other professions, and it's an absolute crock of shit, and it's actually very disrespectful. Even if the information that you do have may be more effective, it's actually intellectually very egoistic to think that you can't learn from those professions.
yeah, look, I completely agree. I think we have to acknowledge some of the limitations, in addition to the strengths of how we view musculoskeletal problems, or to be honest, any type of health related problem, because there are very strong limitations, and we see that uh, in our own biases and how we view things. And so, like, going to your point here of, I'm just thinking about how we
Well,
phrase this.
I've got a couple of thoughts that I want to put forward. Maybe that
Yeah,
this
go
will
on.
jog you. So, two of them are that one, obviously, we're dealing with an environment. When you learn something new, you're dealing with an environment of uncertainty. You don't know what you don't know, and you also, when something becomes obvious to you that you don't understand it, you do have a decision to make. All right, and that decision is framed in your ability to, as I said, lower your intellectual ego and put forward a concept of whether you're willing to suggest that maybe you don't know that, and potentially, because I think this is an important part, and I'm stealing it in a way and steering it in a way so that I can bring you this quote. But whenever we get something wrong or whenever we don't know something, personally, I think all of us see that as some sort of failure on some level. And our
Mhm,
society and the way that we're taught and the way that we see the world is that we shouldn't fail, and failure is the worst possible thing that can happen. However, I
mhm,
think that that is the most important way for all of us to learn. And I think it's the way in which we learn the most. And I don't think there's a clinician out there who won't say to you, and any professional really, that they've learned more from their successes than they have from their failures. Like if they have,
mhm,
that they're very, very, very rare people, and I congratulate them. Because
mhm,
I know that getting kicked in the ass by making big fucking mistakes is the way that I've learned way more than I would ever learn being right about something, right? And
mm,
it's the same with when you realize you don't know something. So, I said I had a conversation with a friend of our show, David McCloskey, and it was really interesting because I was talking to him about a few ideas and some different things that I'd been working on. And he started bringing up some concepts that I had never ever heard of. And I had that oh shit moment of like, fuck, I
mm,
don't know anything about what he's talking about. And I had to very respectfully be like, I don't know what that is. Can you explain a little bit more? Or where do I go and learn a bit more about that? Right. And it was
mm.
actually, on reflection, it was really nice to be in a position where I was like, actually, I don't know anything about this. And I did have to make that choice though of going, I can hide that I know nothing about this, or I can actually admit I don't know. Maybe I want to learn a bit more because it sounds like it might help me. I've got to actually admit, and ask him, where do I go look for more information about this?
You made me think of something just now, and a lot of people will say you should surround yourself with people who are smarter than you, which I completely agree with. But it makes me, I think
Well,
it's actually, you
sometimes
need to take
also
it a step
people who are
further.
dumber than you too, because they come up with ingenious ways of solving problems that you wouldn't have
Well,
thought about.
that that's true, but I think perhaps another element to that is you don't necessarily surround yourself with people who are smarter than you in a particular topic yet
Yeah,
you know.
yeah.
Because don't get me wrong, like you might, for instance, know a certain amount of knowledge about, I don't know, muscle architecture, and you want to expose yourself to someone who knows more than you. There is potential value in that. But perhaps the thing you want to do is expose yourself to someone who actually has a completely different philosophy or set of knowledge and skills that you actually have no idea
Hmm.
about. Because that is where the true knowledge comes. Because it's like you said, it's going to that point of discomfort of going, okay, I actually don't know this. Now, the question you need to ask yourself is, why don't I know it? Is it because, again, limited to some of the biases or perceptions in the environment that you work in, or the knowledge that you've already gathered, and realizing, okay, I know this part of the pie, but I actually need to expand it out. And, through that process, you might come to the conclusion that perhaps this is not useful knowledge for me in terms of what I want to pursue personally or professionally. But you actually need to go on that journey of going, well, what is this information, and is it of relevance or use to
Mm.
me? And again, this comes back to, say, the experience we had
This individual.
with someone
Yeah.
that we presented to. But again, I think it's the same thing too. Of do you need to go and speak to that osteopath that who has a very different philosophy and approach to how they deal with pain or musculoskeletal problems, because maybe they give you insight information into things that, although you might find quite uncomfortable to begin with because it's so unfamiliar to you, but overall it builds a better framework for you to have better outcomes with what you do.
Mm. I think it's huge because, as I said, there is this sense of dread that when you realize you don't know something. And I do think on a personal level, we see it as some sort of internal failure. Like, I don't know this and therefore I'm
Mm,
stupid, or
mm,
I've missed something, or whatever it is. And I think it's really important that you continue to take that mindset of like, my job is not to know everything. My job is to continue to explore. Um,
yeah.
and I think that that's really key. And as I said, I was preparing for this and I was looking for different things, and then I came across and it's more to do with failure than it is maybe to do with the learning side of things. But I think that they're intertwined because, to me at least, it seems like that discomfort that you get when you get something wrong or when you don't know something is the impetus for us. It's the stressor that we kind of need to create, that motivation to learn. And it's from Winston Churchill, and it's everyone would have probably heard of this quote before. But it's, success is the ability to go from one failure to another with no loss of enthusiasm. Maintaining your passion. I think that's
Mm,
so key. Of like, just because you don't know something shouldn't be a demotivator. It should be the impetus to say to you, okay, I now need to go and explore this a hell of a lot more, because
mm,
your passion, hopefully, as a care practitioner, is to build the best skill set and toolkit and team around you to be able to get really good outcomes for the people that you're working with, right? And in order to
mm.
do that, you can't be deterred by not knowing something or getting something wrong along the way.
Yeah, look, I even think for you and I, it's something that it's the reason why we do the podcast. Is the reason why I think you and I work well together. Is we both have a genuine curiosity to expand our knowledge, our understanding of possibilities, and like it's something that it's the reason why again we do the podcast, or we for instance are like to be involved in education, because we also want to be able to have those conversations with other people. And I think that works both ways of like, here, we've got some ideas, let's put them out there. What do you think? And at the same time, too, like I would encourage people who listen to us or have heard us speak before, if you disagree with
Say
something,
it.
it's something that it's something that we actually want to have conversations about, not to be able to justify to you or to ourselves that no, we're right and you're wrong. But to be honest, I would love nothing more to have a group of people who can criticize us and challenge us to go like, actually, are we actually onto something here, or are we just actually talking crap? Or are there still limitations and gaps within our understanding?
Well,
Because I think that's the way that we continue to pursue and push the
I think, as
boundaries.
I said, I think it comes to the underlying philosophy that we discussed a few episodes ago, obviously in the evidence-based practice one, but even just about science in general, right? It seems
Mm,
like science is being done in the direction that is often now, and I think this is the biases that you spoke about in research and researchers and the design of particular research, is being done in a very much a verification model rather than a
mm,
falsification model, right? And what I mean by that is people go searching for evidence that supports their hypothesis rather than trying to find evidence that falsifies their hypothesis or disproves it. And it's much easier to find one slither of information that proves it or supports it than it is the moment you find one that says that it's wrong. It probably discounts the whole hypothesis that you're working with, which is why
yes.
people like Karl Popper, philosopher of science, his whole idea was this methodology of falsification. And I think it's a much better standpoint to work from in your development of your hypothesis, whether that's a working diagnosis, or a management plan. We've spoken a hell of a lot, obviously, about safe to fail experiments. It's coming up with a hypothesis for what you think is going to be the intervention that works or that you need to test, and you go out and do that, and you're looking actually for evidence that says that you're wrong, and therefore you need to
Mm,
redefine. Because if you're right,
mm,
it means that maybe you can amplify it. But if you're wrong, you need to wholesale get rid of that, right? Particularly if it's a
mm,
significant failure of whatever your hypothesis is. And that change in mindset, I think, gives you a lot more freedom intellectually to think that being wrong is actually a good thing, because that's actually the outcome I'm looking for. And I think that you mentioned it before, I think it's really, really important and really valuable. If you go speaking to people who know a lot about areas that you don't know anything about, but you know that they're a very well educated person in their field, they're going to show you and give you opportunities to explore not only ideas, but even frameworks or concepts that maybe aren't applied in your area of expertise. And that starts to open up your
mm,
mind to, okay, there are ideas, there are concepts, there are philosophies, and there are principles that I don't understand. And that
mm,
actually is the reason that I'm talking to these people. It's not to get the specific information. Like, obviously you and I have spoken to, data scientists, we've spoken to lawyers. We're not ever going to be lawyers, or we're never going to be a data scientist, or I don't think, at least, right? But the principles that they use and the frameworks that they use may be very valuable for us to go, wait a minute, that really challenges and maybe even refutes the way that I approach this problem. And I need to think about this in a very different manner. I think that's really
mm.
important because it flips on its head this idea that you're always, as you mentioned before, searching for information that confirms what you already think. It's confirmational bias. And it's so dangerous.
The thing I think of too, and we've had this conversation offline before. One of the great things about current society is there's access to so much information when you think about social media, podcasting, and so on. And I know that you and I are the same. Of we don't listen to any physiotherapy podcasts,
That's
and
probably,
look,
to be
that's not
honest,
to
that's
say
something that's probably a failure on our end. And we need to be open
that
to that more.
for sure. I was just going to say it's not to say that there aren't things that we could learn from listening to some of these things, because I have no doubt that we could. But it's more of being exposed to ideas that don't fit in within the conventional information that we receive. And look, maybe that means going to listen to physiotherapy podcasts in other English speaking
Hmm.
countries. Maybe it
That's
requires you to go and listen
That's a
to,
really, because I want to talk to you about this, because obviously you're exposed to this now. One of
mm,
the things that I noticed being
yeah,
overseas, and we spoke about this, is the way in which people approach knowledge gain is very different
mm,
at times from different cultures. And I think that that's something that we disregard, particularly if research is written in another language. There's whole parts of research
oh
that are
yeah,
missing because it's all in Chinese, or it's all in
yeah,
it's in
yeah,
Portuguese because it's from Brazil, Brazilian physios or whatever it is. I think that that's a real fundamental flaw, that we have this concept that if it's not written in English, then it's clearly not valuable information. Especially in the physiotherapy world, I think there's been a lot of research that has been neglected because it's seen as being less than due to language.
yeah. No, look, absolutely. And again, even just thinking about researchers outside of Australia, because, you know, physiotherapy is relatively well developed and held in high regards in Australia. And we do have a lot of people doing research, and actually, some of it's really good research. But again, we need to understand that there is a whole wide world outside of Australia, with people generating lots of research and lots of ideas that uh, we're unfamiliar with, and maybe even times contradict some of the concepts and beliefs that we have. And I think it's actually important and necessary for us to make sure we're exposing ourselves to ideas that we're unfamiliar with, and at the same time may actually go against what you believe. Because not necessarily that you need to say that there isn't any value in what you're doing already, there probably is, but you also might start to see some of the limitations or some of the potential benefits of applying other thoughts or other ways of viewing a problem or other types of intervention that essentially just give you more tools to your toolkit, essentially just give you more opportunities to explore different plans that lead to you getting better
Yeah,
outcomes.
yeah. I think like we probably covered off on most of the things we wanted to discuss, but I think it's just you hit the nail on the head there. Everyone is given the opportunity to explore more information, and now in the world, as you mentioned before, we have such great access. You would be really
Mm,
remiss to not go exploring it and to talk to people, because I think one of the beautiful things about this podcast is probably highlighted to us is if you're willing to, afford someone the time to talk about what they do and their ideas, they will be kind enough to share them with you. And it's been a really nice part about this process for us. So I think that when people go out of their way to share information with you, even if it contradicts what you currently think, it's worth the exploration to talk about them, to talk to them about why maybe it differs, and where you can learn from each other. And maybe you won't meet in the middle, but that's part of the process in itself, and it requires, as we mentioned earlier, like letting down your intellectual ego to open up the opportunity for some new knowledge.
yeah, and really, it's somewhat of a philosophical discussion, but it does really require us to reflect on, like, do I have any particular biases, or am I someone who, as soon as I hear about this particular intervention, I just contract and go like, "Oh no, that's not of value or goes against my belief
Hmm.
system." Now, again, if it's something that is well thought out and you've come to that conclusion with trying to be much more open to different perspectives, then of course that's fine. But if you are simply ignoring or denying a particular bit of information or some type of intervention or belief because you've been indoctrinated into thinking that, that's where I think it's really important to challenge your own potential
Hmm.
ideology, because we have to understand that we are indoctrinated into a certain way of thinking, and there may be potential strengths with that, but are also limitations to
Hmm.
it.
No, perfectly put. All right, you've given me an idea. I think we should do a podcast at some point. We'll probably be the only ones to ever listen to it, but on bias management and some ideas that we've spoken
Yeah.
about before. A lot of people would obviously be very aware of a lot of the research that was put forward by people like Kahneman and Tversky, with their Thinking
Mm.
Fast and Slow, and a number of other researchers on this. But I think it's something that we could definitely explore because it's a big area and it really affects our decision making, and we've just discussed our learning as well. So, um,
Yeah. I was just going to actually say, and I've mentioned this before, but considering the topic of discussion, I think it's worth highlighting that, for the people who do listen to us, please always feel free to reach out to us about whether you agree, whether you disagree, whether you think that there's something that we should look into because we're unfamiliar with it. Because one of the biggest things that we aim to achieve is to share our own ideas. There's obviously limitations to our ideas, of course, but also, we really do want to build a bigger community of people that we can have discussions with about this, because we realize that the more input we can get from different people and different perspectives, the better outcomes we all
mm.
have.
Jack, thank you so much for taking time out of your day. It's getting dark here, as you can see, so
Pleasure.
I'm going to jump off. But thank you very much, mate, and thank you to everyone for listening.